Good evening to you all. And this is a program for PGs done by SOGO. And I think I won't stand between you and Dr. Srivatsan. Kindly go ahead.
Thank you, sir. Right. So this is basically a resident-oriented program. This is called us back to the basics. So today, the topic that has been given to me to talk about is the investigational pathway for a patient with elevated PSA. Now, this is a very simple topic if you can consider that, and that's also has it's a lot of complexities attached to it in view of the confusion. When you sit in a clinic and you have a patient walking in with an elevated PSA, there are so many do's and don'ts. As at the same time, there are so many factors that you have to factor in before you can, start doing the investigation. The idea of this talk is to simplify that process to understand what should be done and what should not be done when a patient comes in with the elevated PSA. So for this, I'm going to touch upon a little bit of theory to understand what is the concept behind what we are going to do, and then talk about the diagnostic pathway as well. So this is the way the slides are going to be. Diagnostic pathway, PSA kinetics and PSA, MP-MRI and PET PSMA, because those are the younger ones on the block now, and when to do a biopsy. At the end of it, we'll have a small case-based discussion to understand whether this is same replicated in the clinical scenario as well. Now, we all know of the old pathway. I mean, this was what was taught to me when I was a postgraduate as well. A DRE is a must. We do a PSA testing. If the PSA is more than 4.1, the chances of positive predictive value is about 30%. If it is between this thing, it's about 37%. We do a truss. We find any nodule or not, then it depends on that, and we do a truss-guided biopsy. Very rarely in those days, we used to do an MRI, but it was a plain Jane MRI for T staging. Mostly after a post-biopsy, where you have to look out for hemorrhagic spots as well. And then we do a cross-sectional imaging to rule out lymph nodes and bone scintigraphy for metastatic workup. This was how a patient with prostate cancer was approached to whenever he walks into the OPD and so forth. So what has changed in this thing? Now, this change has been very dramatic in the past decade. We have completely changed how we evaluate a prostate patient, and it's lots to do with the MRI and the PET-CT, PSMA PET, which has come into So what was actually a 6 and a 12 fluor systematic biopsy has turned into a targeted plus systematic biopsy. We have PSA, not only PSA, we have variations of so many things that it's confusing to us itself, how to practically use it in the clinical practice. And finally, trust. I mean, it has been relegated to the just for the biopsy sake. We have MP-MRIs which tell us what is where and how to go about it, how to grade it, and so forth. We do have a transperineal biopsy which is coming up in a big way, and PIRAT score, which is completely evolving every 5 years. We have version 2.1 now. So bone scans and CT is almost out, I would say, and we have gone on to what we call as a PSMA PET-CT. So if I could say the gist of the entire slide, it is this. So this was the traditional pathway on the left, and now we have the more what you say as a recent pathway that we have. You have a raised PSA or an abnormal DRE. If there was even one paper, is DRE really required in these days to understand whether CA prostate is there or not? But as clinicians, I feel that a DRE is a part and parcel of it, and you have a satisfaction when you slide that mucosa over the prostate to understand what stage it is as well. So when you have an MP-MRI, if it is negative, then you either do a biopsy, or if there is a high risk nature, then you do a biopsy. Then you do a PSMA with the surveillance and so forth. If you have a positive MP-MRI, which is basically PIRATS 3 above, then you have a targeted plus systematic biopsy. Then you prove it, and then you stage it with either a bone scan or a PET-CT. So this would be this thing. Now, let me go on to the PSA part of it, because that's where most of our patients starts their journey with prostate cancer as well. We all know the history. It's not a very old protein. It's hardly been there for 50 years now. It actually came to be associated only in 1981, after which I would say it has been at one point a hero and now a super villain as well, because you overdiagnose is what they say. So it is a serine protease. It's a member of Kallikrein. We all know that. Now, the most important thing I want you to understand from this is the variations of PSA. So we have the PSA, which is both complex or free. Now, this complex PSA is attached to various, carriers like ACT, macroglobulin, and APIs, and this is how the percentages look like. And once it is processed in the prostate and then comes the pre-PSA, basically pre-PSA is getting degraded into pro-PSA, PPSA or benign PSA, and other PSA, including IPSA, which is called as the intact PSA. Now, this is very important because nowadays, I think these molecules, which are degradatory, have become more of a specific marker than the total PSA itself. Total PSA is the free PSA is mostly associated, if you see the next slide, mostly is less than produced in the case of malignancy, whereas it's more produced, total PSA is more produced as well. Now, if you see the specificity of the PSA, it is said to be a very organ-specific tumor marker. However, you should also understand like breast tissue, breast milk, kidney, adrenal, parotid also express a small amount of PSA. If you see a PSMA PET CT, you will see a little uptake in the parotid gland as well. It is disease non-specific, and that is the most sad part of PSA, because any disease involving the prostate can cause an elevation of PSA as well. So you should also understand it is a continuous variable. There is no normal value. We keep speaking about PSA less than 4 and greater than 4. That is an arbitrary value that we have arrived at in order for us to understand how to go about evaluating a patient, but it is a continuous variable. It is not a static variable. There is no normal value per se, and the probability is what we understand is to corresponding to the PSA value as well. So as we come to we all know this is a straightforward exam question. What are the variations in PSA due to what, including BPH, drug-induced detection, ejaculation, cycling, bacterial infection, massage, instrumentation, biopsy, and so forth. But what is it? Let's get to the specific of it, because I think we do not know the specific of what. Now, DRA at one point was said to be that if you do a DRA, you should not do a PSA. Now, that's out, as we know that the variation is very, very transient and very, very minimal. So you don't bother about it. We can always go ahead and do it. Ejaculation does increase it by more than 0.8 nanogram, but they usually return to normal within 48 hours. Bacterial prostatitis, you should not do a PSA. You have to wait with antibiotics at least for 6 to 8 weeks. Prostate biopsy is the one which elevates the PSA to the max. It's about 7.9 nanogram per deciliter within 4 to 24 hours itself. So you have to wait at least for 4 to 6 weeks before you repeat a PSA. TURP can obviously elevate by a median of 5.9, and they will return back within a month or so. And a screening PSA should not be performed for at least 6 weeks following either of these procedures. So the ideal in this thing is to wait for 6 weeks before you repeat a procedure. Now, this is very important for you to understand, especially if you're doing an initial PSA test, not for follow-up as well. We all know the medication, how to calculate, how it gets halved by using, finasteride or dutasteride. The one thing I would like to mention is the use of steroids. Now, there is an significant increase in PSA expression by betamethasone. It is through the transcriptional activation of the androgen receptor as well. AUR, as you all know, elevates the PSA, but the levels can be expected to decrease by 50% within 1 or 2 days following resolution. However, please do not do a screening PSA during the period of AUR, at least wait to 2 to 4 weeks. Now, what are all the attempts that has been done to improve the sensitivity and specificity, since we know that it is not a very sensitive or specific test? So we have the age specific, the density, the free PSA, PSA kinetics of velocity and doubling time, and PHI, and so many other tests which has come. So we do have a age reference PSA. So this is a Western value. So do we have an Indian value? Yes, we do have an Indian value published by the Nadiad group. So this is, if you compare it with the Western value, you do find a reduction in the PSA value to what we have been following the Western pattern of like 2.5 and 3.5 and so forth. If we see the Indian value, it's actually less. We have always been conventionally told, because of the increased risk of infection and the incidence of infection, the PSA in the Indian population is slightly higher, but that is actually not the case. It's actually lower than the Western population, and our incidence of cancer prostate compared to the Western population is also not too high. Now, is there any value of, relationship of the PSA values? Now, this is the risk of cancer prostate depending on the low level of PSA values up to 4. So do you have incidence of prostate below 4 also? Yes, we do. But if you take, it's about 26.9% actually. But if you take the risk of more than grade 2 cancer prostate, it's only 6.7%, which is quite low. Coming on to the next parameter, which is the PSA density. Now, we all know it is per unit volume, and it's also, there is a entity called PSA TZ density, which is basically transitional zone density. The actual value of this parameter is actually not very clear. Now, we have the values, we are not standardized the values, so it's better that we avoid the terminology as well. Then came the free versus the total PSA argument. Now, this is the AAU guidelines, which says that it was detected in PSA value between 4 and 10 in about 56% if the ratio is less than 0.10, but only in 8% if the PSA ratio is more than 0.25 nanogram per deciliter. Now, this is very, very significant. However, they also warn you that it is of not clinical use if the PSA value is more than 10. Now, with the advent of MRIs and pyrites scoring, I don't think this ratio is going to make much of a difference. You're anyways going to get a MRI done. PSA kinetics. Now, there is always confusion in the postgraduates between doubling time, velocity. It's very simple. If you do not know the diagnosis of cancer prostate, it's called a velocity. You're trying to track the velocity of PSA. If you know that the patient is having a prostate cancer, you're basically looking the time taken for the PSA to double in an already known case of cancer prostate. This is the basic difference between velocity versus PSA doubling time. Now, again, velocity is a bit dicey. It has various cutoff sensitivities. There has been numerous papers which is published. Nothing could be, solidifically standardized to say that this is the way we have to diagnose it. For example, for PSA of value between 2 to 4, the velocity of even as low as 0.1 nanogram per ml per year can predict probability of cancer over 10-year period, especially in less than 50. So what was the proposed cutoff for less than 50 is about velocity of 0.2 to 0.6 in patients of PSA between 2 to 2.5. However, for PSA between 4 to 10, the cutoffs of 0.35 to 0.75 change per year has been used with relatively high specificity, however, low sensitivity as well. So finally, do we use PSA velocity regularly? It's not shown to be of much use in the population level. However, if the velocity is high, then you should always garner that there is a chance of high-grade cancer as well. Now, coming to the PSA doubling time, we all use PSA doubling time in our clinical practice in any case of treated carcinoma prostate. So this is not with regards to the diagnostic capability, but it's as a follow-up and a prognostic capability. So for monitoring, prognostication, active surveillance, especially very, very important. Post-RP biochemical recurrence, post-RP cancer survival mortality, post-RT, very, very important, and as well as in CRPC to understand what is the prognosis of the castrate-resistant prostate cancer. So there are some rules when it comes to PSADT. So it should be at least 3 PSA measurements. A minimum time period of at least 4 weeks is preferred due to potential statistical noise that could occur. All PSA values should be more than 0.20 nanogram per ml and following a global rising trend. All included PSA should be obtained within the last 12 months, preferably to understand the current activity. And it's often mentioned in months or in weeks in very active, not in years as it goes to the velocity. Velocity, at least a year should be required in order for you to say that it has progressed and so forth. So this is the most important fact about PSADT before you go on to that. So coming on to the PSA isomers, as I was saying, these isomers have become the newer ones to help us identify in a better way which patients to basically probably get an MRI or to do a biopsy as well. Now, these, especially the -2 pro PSA, is markedly higher in cancer prostate than in benign settings. The use of this biomarker significantly improves the detection when compared to the ratios as well. Now, we all know that these all belong to the HK family. Now, we should understand that PSA is actually more strongly expressed in benign epithelium than the malignant. It's basically the leaks of the PSA that we are detecting, whereas HK2 is strongly expressed in malignant tissue, probably leading to the better predictive value with the help of this thing. So what they did, they mix and matched everything together to see whether there is a better predictive value without it. So that landed up in what we call as 4K and PHI and so forth. So what is a 4K, sir? It's still a proprietary test by OPCO. We do not have 4K testing in India yet, is what I understand. So we have the total PSA, the free PSA, the intact PSA, HK2, which is the latest one, plus age, DRE, and prior biopsy status put into the entire formula. There is a calculator which calculates this and tells you the risk of aggressive cancer that could be present for this individual patient. And then you decide whether to go on to get a biopsy if the biopsy has not already been done. The more suitable, for example, for an Indian population is what we call as a PHI. You can do it yourself as well if you can get the -2 Pro PSA testing done. So it's the total free and the Pro PSA testing, which is called as the Prostate Health Index. It has a clinical specificity of 23 and 31%, but a sensitivity of 95 to 90%. Basically, it's found to be a strong predictor, especially in the range of 2 to 10 PSA. Also, it has been found to have a better correlation with the grade of the disease. It has been approved by FDA and has been supported by the Australian Melbourne Consensus on PCT as well. So this seems to be a better modality for us, especially in the Indian population, to check it out, and everybody should be aware of this testing as well. So these are all the various other factors. I'm not going to go into that for the lack of time, but understand that confirm MDX is a tissue-based testing and not a urine or a blood-based testing as well. Everything else is urine and testing. So I'm not going to talk about the PSA screening part of it because of the lack of time, and it has no role in the diagnostic dilemmas that we are facing, but you should understand that there are lots of variation. The only concept that has come into the last AUA and the EAU guideline is basically discuss with the patient. That's what they have all said. You tell the patient that you can be overdiagnosed and then do a PSA testing and not do PSA for everybody who walks in as well. So coming to the germline mutation, before I go on to the imaging modality, because that's also a part of the diagnostic, whether to do it or not, we all know that there are a lot of germline mutation plus a somatic mutation acquiring during the course of CA prostate. BRCA2 being the most important and the common part of it as well. So is there any guidelines as to who do we test? Sadly, even now in 2022, we do not have the 23 guidelines as well, don't have much clarity as to the germline testing of it, not for the somatic tissue testing. So to brief it for the resident, if they ask you in whom will you offer germline testing, I would say in a metastatic prostate cancer, in a known mutation in a cancer susceptibility, family who has had history of genetic prostate cancer, family history of hereditary syndromes like prostate, breast cancers, ovarian cancer syndrome, Lynch syndrome, and so forth. Tumor somatic sequencing, especially to look out for mutations, specifically BRCA2, ATM, MSH, and so forth, in order to proceed with the treatment with targeted therapy like olaparib, and high-risk localized disease has been added to the NCCN guidelines recently. So these are the indications of a germline mutation testing in this thing as well. Now, coming on to the imaging part of it. Now, we all know that the various imaging used is an MRI, a bone scan, and a PET. Let's keep CT scan out of this in order to this thing. So we used to use TRUS for this, but then we had a lot of misses and hits with the TRUS. It's not a bad modality. It's a good modality, but then we have better modality, which is there. So when it comes to MRI, it is the loco-regional staging as well as a nodal staging if a very well MRI done. We have had a difference in the various sequences. It has evolved over the last 20 years, I would say, rather 15 years. So we have the T2 weighted axial and coronal images. We have a B value, DWA or diffusion weighted images, and ADC count coefficient. T1W for pre-contrast and hemorrhage, and DCE, dynamic contrast enhancement, and one large FOV field of vision up to aortic bifurcation to look for nodes. So this is the protocol generally followed in most of the centers doing multiparametric MRI for prostate cancer. So what is this multiparametric MRI? So we all know that there are three components to the multiparametric. Basically, the difference is what the previous MRI was looking at is an anatomical MRI. What we are looking at is a functional MRI. You look for cellularity. Is there an increase in the cellularity? Is there an increase in the vascularity? Cellularity is looked up by the DWI or the diffusion weighted by looking at the ADC, whereas the vascularity you look at by the dynamic contrast and the contrast leakage that occurs in the tumor cells. And the last one that was added in the multiparametric was the spectroscopy, where you have a choline peak and a citrate trough as well. So these are the various components, and this has to be very, very clear in your mind, especially for the residents and point of view. So what does it look like? So these are the various images that you can see the images that can be seen. You can see a T3 image basically here showing the this thing. Here you can see the diffusion weighted as well as the large prostate with a small nodule that you can see in the periphery in the T2 axial and so forth. So basically, what are we looking at? So basically, the cancer prostate lesions looks like an hypo-intense T2 weighted in this thing, often very irregular and ill-defined. Now, when it comes to diffusion weighted, you all know that the tumors are hypercellular. So basically, diffusion is dependent on the free random movement of the water molecules. So if you see here, so basically the normal tissue versus the tumor tissue, there is a difference in the movement of the water molecule that occurs inside the this thing. We have a tumor cell that's not going to move very, very well. And that is what is called as a restricted diffusion, whereas there is a free or a random movement in the case of a normal non-cancerous this thing. So if you see the perfusion effect of the diffusion, you can see a noise that can come in this thing, which is basically a higher B value. In order to simplify things, if you have a B value, it is bright. You can see the brightness in the lower part. And when you come to the ADC, it is dark in the ADC mapping. And that is how you differentiate between this. Is very, very important in the BI-RADS scoring. And that is how they usually do the BI-RADS scoring as well. Now, coming to the contrast, gadolinium contrast is used and you do what is called as a dynamic contrast enhancement. And this is how it's going to leak. And the capillary leak is what is going to cause the increase in the detection of the tumor as well. However, prostatitis and BPH can also confuse the picture as well. So basically, what does it look like? Restricts diffusion, DWI bright, ADC dark, T2 hyperintense, ill-defined, DCE early wash-in and washout enhancement with gadolinium. So this is the picture that you're looking for in a cancer prostate. And this is the most important slide in imaging for this resident as well. So let's get on to the PI-RADS. So this is the PI-RADS scoring 1 to 5. I'm not sure you know that 1 and 2 being more of a benign, 3 is indeterminate, 4 and 5 more towards the malignancy as well. So this is the various imaging. You can see what are the changes that has occurred. I'm not going to go into the details of it for the lack of time, but please go through it. I will share the slides as well. So coming to the difference between version 1 and version 2, understand that spectroscopy is out. Nowadays, we do not use spectroscopy in version 2, and dynamic contrast enhancement is only relegated to the clarification role in peripheral zone assessment, not for diagnosis as well. This is very, very important because whatever I've spoken about was more into the PI-RADS 1 part of it. When it comes to diffusion weighted, has been given the maximum. So you actually don't even require contrast if you can clarify it even in the what we call as the almost in a shortened version of BI-RADS. T2 weighted images have a greater emphasis for transitional cell. On an overall basis, PI-RADS version 2.1 has a pool sensitivity of 89% with a specificity of 73% for detection. That is excellent improvement over the PI-RADS 1 score as well. This is the representation where the colors are used to represent starting from 1 to 5, showing various individual differences. That is very, very important in order to, it's more of a radiological this thing as well. Now, comparison between biparametric, and this is going to be an important question because many of the Western countries, especially the UK and the NHS, due to the financial constraints, are moving towards biparametric and not multiparametric. And this is very, very important. It's almost, especially in a high-grade disease, to see the accuracy, it's almost the same accuracy, and that's very, very important. So what is the difference? You have a multiparametric, it involves DWI, T2 weighted, all images, and DCE. You skip the DCE, that becomes a multiplanar biparametric MRI. You skip the T2 weighted sagittal and coronal, it becomes a single planar biparametric MRI. We are cutting it short. What is the advantage of it? You also cut short the time the patient has to undergo the investigation as well. So this is very, very important. You save money. You do not give contrast in many times. And third, you save a lot of time as well. And this is especially in a populous country like India, makes a lot of sense. So can biparametric replace? Definitely it is equivalent. It reduces the high cost and you don't have to give gadolinium contrast. However, if you are looking at detecting the ECE or the extracapsular extension, or you have to follow up the patient for active surveillance, it is still slightly inferior to multiparametric. I would prefer for a multiparametric MRI as well. I still write MP MRI as a routine as well. Also, there has been as I said, fast BP-MRI when compared to standard BP-MRI, and this is probably going to change the way we do scans as well. Now, coming to the molecular imaging options, I have only 5 minutes left, so let's hurry up. So we had the bone scan, we have various PET-CT, so I'm going to skip most of it. Colin, let's come to the PSMA PET, because that's what we have in India, and that's the commonest test that's been done all over India as well. So this is the PSMA molecule, and that's what it gets exposed in a case of a CA prostate, and that's where it's going to be uniformly overexpressed, and that's going to lead to the detection of the cancer as well. So basically, this is very, very important. You have a small nodule that is there, and this pickup is what, and the SUV value is what tells us whether it's an active lesion or not, especially even in the follow-up as well as in the diagnostic. This makes a lot of difference. So what is the role of diagnosis and this thing? So basically, where does this come in? Does it come in T staging? No. MRI is the king in T staging. There is no role of PSMA PET-CT. You can prove the activity and so forth, but doesn't do T staging. Does it have a role in end staging? Definitely in intermediate and high risk group compared to other modalities like CT and everything. Basically, it is a very good modality to tell us that the nodes are involved, and if so, what is the activity that is there? If the sensitivity and specificity of choline being 62 and 92%, whereas in the if you come to the PSMA PET, 65 to 77% of sensitivity, almost more than 95% of specificity, and makes way better modality, I would say. And even in this European thing, most of the talks were about the role of PSMA in early diagnosis of prostate cancer as well. So this makes a lot of sense. For M staging as well, bone scan being cheaper is used very commonly in India, but again, PSMA PET is superior. It can also pick up lytic disease in comparison to sclerotic disease, and makes a lot of difference, whereas bone scan can only pick up lytic disease as well. So when compared to even whole body MRI, I know many people do an MRI with screening till the entire spine and everything. PSMA still scores superior to that as well. For recurrent detection as well as this thing, PSMA is again the go-to test as well. So coming to the indications for biopsies and everything, just a brief note on how to this thing. The preferred modality, I would say, is more going towards Trexit or transperineal biopsy, and the prophylaxis is also changing. If you see here, phosphomycin, this is the latest guidelines that has been put forth by the EAU. Phosphomycin has come as the single modality of antibiotic preferred in a case of, especially if you're going transperineal, whereas in the case of a transrectal biopsy, still the old protocol stays. So is there any major changes in the prostatic cancer diagnostic pathway? This is the latest Nature review in the clinical oncology. So whatever we have spoken about till now, a biomarker-based pathway, including 4K, PHA, and everything, that will decide whether the patient will undergo an MRI or not. If so, what is the biopsy, whether to undergo it or not. So put together, that will decide how you go about evaluating the patient as well. And with that, I end the theoretical talk of the diagnostic pathway. Would request any comments from the panelists as to any addition to it as well. Thank you.
Dr. Kulkarni is there? Hello?
I can't see.
You can't see, probably. No, I can make a comment. That's a very good talk, a very elaborate talk you have done, and especially PSA aspect and PSMA PET scan. We all are using these things, and in future, I think things are coming more in this era, in this medical field of prostate cancer, where you have a lot of things coming. But as of now, MRI, PSA, and PSMA PET scan, They help in diagnosis, in treatment, in follow-up, and every aspect of prostate cancer. After that, do you have any case discussion, or
Yes,
who
sir.
is
I
presenting?
have a couple of cases, and a couple of postgraduates have joined as well. I request sir also to be on the panel to add if I miss something also. I have a
Yeah,
few
sure.
very simple cases. I'm not going to do complex cases. Just the what we have discussed as well. I'll share my screen.
Please go ahead.
Thank you. Can the
Yeah, we can see it.
identify themselves who are here? I can see Tanmay.
Yes, sir.
Yeah, and who else? Sorry.
Yes, sir.
Wilson, can I make a small comment?
Yeah, please, sir.
Sorry, Pratik.
Go ahead.
Yeah, one of the issue we are facing is whether we should pool patients for active surveillance, because generally we have got a very small number of patients who is fit for active surveillance. One of the important factor were all the Western molecular markers, or like P and 4K, everything is coming is to differentiate patient for active surveillance or a radical treatment. We have got our own issue in active surveillance because of the compliance issue, high prevalence of high-risk prostate cancer. So we have to evaluate whether this is very much applicable for us, but cost of the treatment. So these are the main issues. So basically, there are a lot of investigation which are important to differentiate patients who is fit for active surveillance among the low risk category. But probably this we have to find out whether this is very much applicable for us, because it is very costly, not available. Third, we have got a very small amount of active surveillance patients who may come back regularly for active surveillance.
True, sir. Also, active surveillance involves again an MRI and other things as well. So the cost burden of an active surveillance is almost as bad. However, sadly, the difficulty in active surveillance in India is the loss to follow-up as well. That makes our life difficult as well. But there are actually more trend towards more active surveillance rather than going for radical treatment, especially for low-risk diseases, even for a certain number of intermediate risk diseases. The point being that we are over-treating. That's been the overall point in the treatment of cancer prostate. However, as sir rightly said, we do not have definition of which is going to be the marker which will tell us that is going to transform from a low risk to a high risk. And that is where we are stuck. And that is why we would rather prefer to give an active treatment rather than to put them on active surveillance. And that I think that's the discussion along with the patient as well. Right. So let me get on to the case-based discussion. And I think we have Dr. Tanmay, Dr. Praveen, and Dr. Mahadev from Madras Medical College, and Dr. Snigdhar from Chengalpattu Medical Colleges. Welcome all. It's going to be a very simple discussion. I would say that I'm not going to make it too complex. So let me go on to the first case. This guy was a 75-year-old gentleman who is a diabetic and a hypertensive. He has been having mild to moderate LUTS for his local urologist. I put him on a tamsulosin dutasteride combination for the last 2 years. He walks into your OPD with a PSA report saying 4.3. You do a DRE, it is normal. How do you go about for this patient? What will you do for this patient? Dr. Praveen? Oh, sorry. Dr. Praveen, yeah, sorry. I'll go just in the order.
Sir, I would like to repeat the PSA after a week, sir.
Repeat a PSA after a week. Okay. Why do you say that?
Sir, because he was a known case of BPH on alpha blockers, and also at present yes, DRE has been done, sir. Actually, guidelines say that we can repeat a PSA to two values elevated will be.
What is your correlation between the patient being on dutasteride and the PSA value? Do you like to do something about that? Do you feel that PSA is normal, right? It's almost 4.3.
Yes.
It's almost near 4. Is there any consideration with regards to that? Or are you alarmed that this is not normal, or you
Yes, sir,
think
it
that
should.
it's fine?
Yes.
Anybody else? Dr. Mahadev, what's your thought
Sir,
on that?
actually, PSA is 4.3, sir. And he's using dutastrate for the past 2 years.
Hmm.
So, I would multiply that PSA with 2 to get a definitive value of PSA, and it falls in the gray zone. So, I would proceed with an MPMRA further, sir.
Okay. Would you not repeat a PSA then? Or do something else like a urine culture because he's a diabetic and so forth? Would you be thinking in those terms as well?
Yes, sir. First, I would start him on antibiotics and repeat the culture, PSA after a period of 2 to 4 weeks, sir.
So what is the ideal gap between the PSAs would you prefer, Dr. Mahadev? Would you do after 2 weeks, 1 week, 3 weeks, 4 weeks? Is there a consensus on that? Like, for example, you start this patient on antibiotic, you give for example, a 2-week course of fluoroquinolones. When will you repeat the PSA?
So after a period of 2 weeks.
2 weeks. Anybody else? Tanmay?
Around 4 weeks gap between 2 consecutive values would give a better.
Sir, to the seniors, what is your opinion on the general gap between the PSA? So when do you actually ask for a repeat? Is it after 2 weeks or 4 weeks, or is there any consensus on that, sir? Dr. Ginil or Dr. Sudhir, sir?
I'll repeat after 2 weeks. If it is still high, I'll go ahead with MPMRI.
Okay,
And
sir.
especially if the urine culture is negative, it is better to do MPMRI.
Okay, sir.
And unless it is positive, then you can give the antibiotic and repeat up to 2 weeks.
Right, sir. So basically, if the urinary culture is negative, there's no point in repeating the culture because we are not expecting anything to increase the PSA. So we would rather go on to an modality to find out what is the diagnosis and this thing. So anybody else have any other diagnostic this thing? Would you like to do anything else other than an MPMRA before jumping onto an MRA, or what would you do for that?
Since the value, the corrected value is between 4 and 10, so we can consider a 4K score or PHI depending on availability. That might be an additive.
Okay. So definitely the value of 4K or PHI is good in determining whether this patient will show something else in MRI. But considering the fact that we do not have the facility for 4K currently in India, and PHI is also slightly difficult and costly, so probably I think the next cheapest modality that will be, I mean, I think sure the 4K will cost as much as a MRI as well in India. So I think the ideal way to go about it is to do a MPMRA directly and that's it. So when it comes to MPMRA, after the talk that you gave, what would be the prescription that you would ask for in a patient of this thing? Would you ask for a multiparametric, or would you ask for something else, or you rely saying that I want a multiparametric and MRI as well? Snail, you are here?
Sir, we'll go ahead with an MPMRI, sir.
MPMRI. Okay. Lately, we have not had spectroscopy coming into the report at all, actually. So whatever MRI that is being currently practiced, I think at least in the metros, is generally a biparametric MRI, I would say. So it's basically more of a contrast and a diffusion weighted images. You hardly see those choline, this thing and all the graph they used to give it the previous MRIs. You don't find it in the latest MRI as well. So I think it's all mostly a biparametric MRI that's being practiced, at least in Chennai. Not sure about the other cities. I think the value of spectroscopy has suddenly become so little and then so less. Any thoughts on that from the senior panelists, Dr. Ginil sir or Dr. Sudhir sir?
Can you just repeat the question?
Sir, spectroscopy has almost gone out of vogue these days. Do you still see people doing a spectroscopy, or just more of a biparametric MRI that we are seeing these days?
No, I'm not seeing any spectroscopy recently because I think that used to be around 10 years back.
Yes,
now
sir.
we don't see any spectroscopy at all because now the PIRAD scoring system is well established. So there is no role for a spectroscopy in the current management.
So when I was an examinee, I mean, spectroscopy used to be drilled up all as well. Nowadays, it's not there at all. So I think a biparametric is what is being done. So calling it a multiparametric is probably no longer the way to go forward, right? So let's go on to the second case. This patient is a 61-year-old non-smoker. We are not going to talk of any therapeutic dilemmas. It's just diagnostic alone as well. So this is a PS1 sexually active without any LUTS and so forth. Now, this guy's father was treated for a metastatic prostate cancer at our institute. Now, he has screened himself for the first time with a PSA, and the PSA value is 5.6 nanogram per deciliter. We have a DRE, which is again normal. So as we discussed in the earlier case, we also did a repeat PSA after 6 weeks with a culture which was negative. Now the PSA is 5.64. Start from the reverse, Dr. Snake. What is your opinion? What would you do for this patient?
Sir, since he has a positive family history, so there he becomes a high risk case, sir. So we should go ahead with the multiparametric MRI, and then depending on that, biopsy.
Patient was found to have a prostate of about 80 cc. Would you still ask for a multiparametric MRI, or would you say that probably this is related to the PSA density is equally okay?
Sir, based on PSA density, if the value is around 0.15, then it indicates that more than 0.15 can indicate high chances of.
So you feel that's okay for that this thing. What about?
But we should go for multiparametrics.
Exactly. So what are the other opinions, Tanmay, Mahadev? What do you feel should be the way to go forward in this patient?
In a normal patient with a large prostate with this, I would have maybe erred on the side of observation, but considering there's a positive family history, I'd definitely go for an multiparametric.
Exactly. That's the reason why that positive history is there. And so this PSA is between 4 to 10. Would you ask for a free PSA ratio in this patient? Why not? Because that's the range where it's actually being used.
Yes, sir.
I think we can do it because it's an easily accessible test. It's nothing complex like PHI or 4K. I think that will add additive value to your discussion with the patient to help him undergo the MRI. But as a whole, we all agree that the next step for this patient, especially in view of his positive family history, would be to do a multiparametric MRI as well. So would you do it before biopsy or after biopsy? I think that's an easy question nowadays.
Definitely before biopsy.
Before biopsy. That's the guideline change that has come in the recent 2 to 3 years, is that MRI is a must always before biopsy, never biopsy before MRI as well. Okay, so this is the MRI report. It says it's a 33 cc prostate. I just gave a 80 cc out of the blue. Intact peripheral zone, Pyrus 2 lesion in the transitional zone of this thing. Now what you're going to do? Are you going to suggest for a biopsy, or what's your plan? Or would you suggest a PET PSMA CT to see the activity as well? Anybody? Tanmay, Mahadev, Praveen?
We have actually not used PET PSMA CT upfront without biopsy in cases.
So would you suggest a biopsy right away then? It's a Pyrus 2 lesion.
Yes.
What's your plan for this patient? This is the patient with a positive family history. What would you do? Are you going to follow up this patient with PSA?
I'd go ahead with the biopsy, sir, just to give him the benefit of that.
Okay, targeting the Pyrus 2 lesion.
We can have a targeted biopsy, sir.
Targeted biopsy of the Pyrus 2 lesion. Is even indicated in Pyrus 2. Any idea?
No, sir.
No, sir.
So I don't think, I think I would still follow up the patient with PSA and then take a call as to this thing, because the Pyrus lesion is less than 3. So in a Pyrus 2 lesion, the chances of your this thing is yield is very, very low in spite of your targeting and all those things. So what kind of a biopsy do you generally do, Tanmay? What is the actual recommended biopsy that you do? How many cores? What is the name of the biopsy and so forth?
It's a 12-core systematic biopsy, and if there is a lesion on the MRI, that is accompanied with a targeted biopsy.
So what kind of a targeting that you do? What kind of a fusion that you do?
It's a,
What are the types of fusion that you do? So we have the cognitive fusion, where you
Cognitive fusion
try to see where the zone is and you target that. Okay. Then we have the actual fusion, where the software fusion is superimposed on the trust machine and you target it. And last is the in-bore fusion, which is basically you do the biopsy in the MRI itself. These are the three types of fusion biopsy that is existing this thing, right? So you would do the targeted this thing, but in the case of a less than PIRADS 3 lesion, we generally do not recommend. If the same thing has been PIRADS 3 or more, definitely your testing. So in this patient, you cannot, according to guidelines wise, even though clinically it may change from person to person, you would not recommend this thing. So anybody would recommend a PET PSMA for this patient? Maybe it will give you better yield. For initial diagnostic, this thing PET PSMA is not recommended unless it's a proven case of where you want to rule out metastasis and nodal this thing. So I think even especially in a PIRADS 2 lesion, your yield of the PET PSMA is also not going to be too high. So for this patient, rather I would recommend possibly follow up with PSA and decide the PSA velocity in order to finally decide whether this patient will go in for a biopsy or not. That would be the way. Again, I note the point that I've said velocity because the diagnosis is not yet reached. Okay, so this is what I would counsel. If he is a very anxious patient, then it becomes a little dicey to counsel the patient as well. However, with the family history, would you do something else for this? Would you recommend for a genetic testing or something for this patient? In a non-proven case of CA prostate, there is no role of genetic testing. You don't even know whether this guy has a CA prostate. He has a higher risk, doesn't mean he has a CA prostate. So genetic testing is done in a proven case of CA prostate, whether it's a germline or a somatic this thing targetable mutation. These are all done only after the diagnosis. In this patient, I would say that you would not recommend all those things till you have a diagnosis at time. Okay, right. So I'll leave that. Now, coming on to the third case. Now, this is a 67-year-old smoker, PS1, hypertensive, sexually not active, complaining of obstructive LUTs for the last 6 months. We do a DRE and you find a nodular grade 2 prostate. And the PSA turns out to be 12 nanogram per deciliter. Similar thing. So what would you do for this? It's already a nodular prostatomegaly. You feel the nodule. What would you do?
So you do a trust-graded biopsy, sir?
Directly go for a trust graded, or will you still do a MRI? That's the question. That's the reason for this case itself. You know it's a CA prostate, but then would you do a MRI or would directly jump onto the biopsy as well? So as I said, it's always MRI before biopsy. Always. That's the main point of this case itself. So you will do an MRI before you suggest for a biopsy, in spite of you knowing very well that this could be a CA prostate as well. Right. So the MRI shows a 40 cc with multiple PIRADS 4 nodules in all the doubtful involvement of the seminal vesicle as well. What would be the target that you would do? You would do a targeting of all the nodules, or would you do a systematic biopsy and targeting of the major nodules as well? Praveen? Or would you do a biopsy of the seminal vesicle?
Sir, combine both systemic and also the targeted biopsy of the major nodules. Sir.
So I think here, since it's involving the entire this thing, the systematic and targeting would become almost the same because you're going to hit all the zones. So I think it will almost be the same, but you are absolutely right in saying that there is no role of doing a seminal vesicular biopsy. It's an imaging thing, whether the seminal vesicle is involved or not. Please do not attempt to do a seminal vesicular or trying to prove that it is involved. There's no point of doing that as well. Right. So this biopsy shows a 4+3 with 10 out of 12 cores positive with a LVI. Would you do a PSMA in this condition? Now we have probably a T3B disease with a 4+3 this thing. So would you be doing a PET CT, or you would already have the plan ready for the management of this patient? When will you do a PSMA PET?
So any intermediate and high risk patient, it is definitely recommended to do it.
So nowadays, I think the guideline says that the PSMA PET can be done for staging purposes for nodal and metastatic staging. But there is, it's only a recommended guideline. It's not a grade A recommendation to do in all patients, but you can do is what they have said. We always do a PSMA PET. The reason being there is a 21% increase in the staging of the disease once you do a PSMA. So basically, we will lose all the surgical cases as well by doing a PSMA PET, but it's always better to have a knowledge that the patient does have micrometastatic or metastatic disease prior to you start, because you will be under treating the patient by doing only a radical treatment to the prostatic primary as well. The last case, just this thing of it. Now, a 49-year-old with a father's history of his cancer prostate, he has started doing his master checkup on routine testing. The PSA was 5.9 because he knows that his father has suffered and he's very, very worried as well. Now, what would you do for this patient? 49 years, 5.9 PSA. No LETS, no urinary tract infection, nothing. Would you recommend an MRI in this patient, or would you like to do something else, or would you like to repeat a PSA, or would you just say, let's follow up the PSA and take a call, because this is not a normal PSA. So what would you do? How would you do a free PSA?
I'd like to repeat the PSA once.
Okay. After 2 to 3 weeks, you repeat the PSA. The PSA is still almost a similar value. What would you do? Would you also do a free versus total? In a 49-year-old, you are considering a BPH?
Yes, but then does the DRE has any?
DRE is normal.
In that case, I'd like to do a free PSA, see if the free by total ratio is suggestive, and then go with an MPMRI if it's within the. Yeah.
Okay, so basically, you do all the tests that can be done before an MRI to see whether you can arrive at a conclusion whether MRI is actually indicated or not, being a 49-year-old and so forth. Yes. But however, with a strong family history, there is a chance that he could still be suffering from cancer prostate at an earlier age as well. The MPMRI shows a PIRATS 3 lesion in the peripheral zone. What would you suggest? Would you be going in for a biopsy, or would you follow it up?
Yes,
I'll go for a biopsy.
Going for a biopsy.
Always going for a biopsy because familial cancers are more aggressive. Okay. So you did a biopsy. You also did a targeted biopsy. But the biopsy came out as negative. A well done biopsy as well. It came out as negative in spite of the target. What would you do? Anybody?
Sir, we'll repeat PSA after say 6 weeks.
Okay. 6 weeks is probably still more higher than before as well because of the biopsy. What is your plan? Like you will follow up the PSA and then take a call again? This is where the PHI scores and the 4K scores come into play, especially in a negative biopsy setting, where it will tell you the predictive value of whether this patient will be harboring from a high-risk cancer. So this is where all those things come into play. And this will decide whether this patient will require a future repeat biopsy as well. Okay, so you will repeat probably these tests, PSA velocity, and then take a call as to the repeat biopsy as well. And this patient probably will require more than a cognitive fusion biopsy, because your cognitive has already probably missed out the active cancer, if any. Okay. Right. So with that, we come to the end of the case discussion. Hopefully I was on time. I would like request comments from the panelists as to any addition to it, or because the case discussion was done only for the diagnostic dilemmas, I didn't go deep into the management part of it as well.
Can I make a comment?
Just 2021, come on.
Hello, Dr. Srinivas.
Yes, sir. Yes, sir. Please, sir, go ahead.
Just wanted to say about active surveillance, which Neil actually raised the point. In our country, it's many times it's difficult to decide whether patient should have it or not, because long term, he has to have MRI and he has to have biopsy also if you go according to the guidelines. And now the treatments are available for such patients, especially who have a small lesion with the low grade cancer, is like doing the focal therapy, like HIFU. You can do hemiablation, you can do acoustic ablation, or you can do MRI mapping of see where the exact lesion is, and you can just ablate that lesion and some tissue around without any side effects. So these things are available. They're already, more than 10 years data. And at many centers, HIFU is being done all over the world now. So that's another option to such patient, and we call that therapeutic surveillance.
Agrees. I think HIFU is coming slowly into the guidelines as well. Till 2022, HIFU and other focal ablation therapies were put under.
Seems there is a connection problem from many places. So if everything is, I think, done, all agrees, then we can sum up and leave. Ginil, can you do that? There is a.
Yeah, thank you, sir.
Yes, Ginil.
So today, Srivalsan was doing an excellent discussion on the management pathway after in evaluation of CA prostate. Like PSA and MRI are the two cornerstones of evaluation. Another thing is we have to decide which patient has to undergo a biopsy, which route is the best option for biopsy, and what is the probable positive rate in each. Like if it's a MRI showing a PIRAT 2 or PIRAT 3, and counseling is very important because unnecessary biopsy can lead on to unnecessary treatment. But at the same time, we cannot miss any prostatic cancer which is clinically significant. So Srivalsan was actually discussing about how, based on the clinical scenarios, he was discussing about all these aspects. So excellent discussion with Srivalsan. So what are the important points you have to look into? Up to PIRAT 2, we can just observe with the PSA. Beyond PIRAT 3 and above, we have to go for a biopsy. And there are some tests that is useful in differentiating we can tell us which is the patient who may have a clinically significant cancer, and which can add on to the MRI. But these tests like 4K, PHI are all not available much. But it is a theoretical question. You have to go through all these things because tomorrow it may come to our country also. So this is the important thing about management aspect. So excellent discussion, Srivalsan. Thank you for coming and doing it.
Thank you, sir.
Thanks to all delegates and PG students.
Thank Sogo for giving me this opportunity. I also thank the residents for actively participating. I hope it was all useful to the resident fraternity to understand because it's not a very straightforward topic as well. Thank you.
Thank you.